Alright, let's do a basic comparison between OG heparin and Lovenox. First, let's look at pharmacokinetics. With heparin, we get a variable response due to binding of plasma proteins in the bloodstream. This is why we monitor it with treatment doses. We use the APTT, or the activated partial thromboplastin time. Enoxaparin has a more predictable response. This is due to its smaller size, as it has less protein binding. Routine monitoring is not recommended, but we can pull an anti-factor 10A level. It might be recommended in patients with renal insufficiency, obesity, pregnancy, and therapeutic failure. Heparin's bioavailability is 100% when it's IV, of course, and it ranges from 30 up to 70% when it's subcutaneous. The bioavailability of Lovenox is about 90%. Heparin has a short half-life of about 30 to 90 minutes, so that's good if someone bleeds as a short offset. Half-life of Lovenox is about 3 to 6 hours. This allows for daily dosing. For prophylaxis, heparin's going to be 5,000 units subcutaneously every 8 to 12 hours. Enoxaparin's going to be 30 milligrams twice a day or 40 milligrams daily. Important to note, we're going to see higher doses with patients of higher BMI, so above 40 and 50. For example, with a high VTE risk bariatric surgery patient with a BMI greater than 50, you might see 60 milligrams every 12 hours. For treatment doses with heparin, we use an IV continuous infusion. So we're going to do 80 units per kilogram as a bolus and then 18 units per kilogram per hour. This is based on actual body weight, and we're going to titrate to a goal APTT range. That bolus is to reach that therapeutic APTT more quickly. The treatment dose for Lovenox is going to be 1 milligram per kilogram twice a day or 1.5 milligrams per kilograms daily. With Lovenox, we renally dose adjust it. For creatinine clearance less than 30 mils per minute, the prophylactic dose is 30 milligrams daily. The treatment dose is 1 milligram per kilogram daily. For side effects, we're going to see bleeding with both medications. Remember, heparin has a shorter duration of action. They both have the same reversal agent, protamine. They bind to the anticoagulant and inactivate it. An interesting side effect with heparin is osteopenia. This is with longer uses of heparin, like greater than or equal to a month. This is because it activates osteoclasts. You can see about a 2 to 3% vertebral fracture risk. One rare side effect is hyperkalemia. This is with long-term usage, and then it's due to decreased aldosterone activity. The biggest thing to watch out for with heparin is heparin-induced thrombocytopenia. This is basically when platelets plummet. It's a delayed response in heparin-naive patients, so it takes a few days, or immediate response in those who have previously received heparin. We see a reduced incidence of HIT with Lovenox when compared to heparin. So advantages of heparin: low cost, able to adjust and monitor it, ease of usage in renal insufficiency and obesity, and we have a long history of use. With Lovenox, we have simplified dosing, predictable response, improved subcutaneous bioavailability, the reduced incidence of HIT I mentioned, a longer half-life allowing for once-a-day dosing, is usually the drug of choice in pregnancy, and patients can administer it themselves, so we can see a shorter hospitalization of the patient with outpatient treatment. So before we start Lovenox outpatient, how much do they weigh? What's their renal function? What's their bleed risk? And can they self-administer it? Health literacy is important with this one. It's a blood thinner.